Now let's get on to the introductions. In the studio with me, immediately to my right, is of course Mike Brown. Mike Brown is a native Houstonian, right? Are you native Houstonian? Native Texan, yes, excuse me, because Texas is a whole other country.
Right.
Texas Heart Institute graduate, been a perfusionist for 38, clinical practicing perfusionist for 38 years. He's done some traveling in his earlier years, but he's spent a lot of time here in Houston. But you cover 10 hospitals.
Right.
And so it's almost like you're traveling in one city.
Right. And with the different progression of companies that bought the companies that I was working for, even within Houston, I've probably done hearts that I would say anywhere from 10 to 15 different institutions in Houston.
That's a lot. That is a lot. And then coming in via Skype, we could say hello to them now. We have my good friend, you know him from previous programs. There he is, John Ingram. And with him today is Aaron Herman. Is it Herman? Is that how you pronounce it, Herman?
Yes, it is.
Perfect. Okay, so John is a magna cum laude graduate from the University of Texas. I was something loud, but I can't say it. And also Texas Heart Institute. He's board certified perfusionist, currently specializing in adult perfusion as well as pediatric and adult ECMO. His hospital does a lot of ECMO, that's for sure. He has several medical patents and has served as a consultant for nearly every perfusion manufacturer. He has published seven research publications in the perfusion literature and has presented both nationally and internationally. With 15 years of experience as a chief perfusionist and 30 years perfusion experience in total, he presently, that might be going up, I think it might be 31 years now. He presently provides nationwide temporary and long-term locum tenens coverage. So welcome, John. Good to see you again. I wish you were here. But you know what? For a one-day turnaround, I think that we need to use technology. Technology was made for this. And now Aaron Herman, CCP. Aaron is a board-certified perfusionist with 12 years of experience. You travel nationally and has provided full-service perfusion coverage to over 20 hospitals. She has been both a perfusion quality manager and a compliance officer, and specializes in complex adult surgeries as well as ECMO. Aaron has a Master's of Science degree in neuroscience. Now that's impressive. Okay, I like that. I just read some of the best articles written by neuroscientists about the residence of the soul. Where does the soul reside? And I tell you what, it was really fascinating. But three of the best articles were written by, one was a neurosurgeon, two were neuroscientists. And you have taught undergraduate and graduate level courses at Kent State University and Brown Mackie College. She considers herself, Erin considers herself, a lifelong learner, I like that, and brings her passion for learning to every account. She has mastered adaptability, resourcefulness, and effective communication in diverse healthcare environments. Erin began traveling after she saw the demand for quality perfusionists expand with the recent shortage, and continues to embrace the challenge of learning the vast array of approaches in perfusion. So welcome, Erin. This is your first time on our program, and we are so happy to see you, and you look great. Your camera lighting is so much better than John's. He looks really bad. We may as well, just cut John out, but you're doing great. But I'm really interested in how this is going to transition when we get this conversation going with your passion for learning, your passion for wanting to teach, your passion for wanting to be taught to, because you can't teach if you can't be taught to, right? And how that works when you go to places where you are the new guy, and how they view you doing that. Are they receptive? Is it 50-50, 60-40, 100%? I have no idea. So it's going to be interesting to hear what you have to say about that. So John, since this was your brainchild, and I embraced it, I thought it was a good one, why don't you kick us off?
Hey, Joe. How's it going, Mike? And good to see you, Aaron. You guys hear me okay?
Yes.
All right,
Yes.
awesome. So, yeah, hey, good to see you guys, Joe. Thanks for all that introduction. And just real quick, yeah, I had this idea a couple months ago. I guess I called you on it, Joe. But the interesting thing is, Erin here, she started traveling through the account that you've been down here where I'm at in Orlando. And as you can imagine, that is not an easy account to travel in and out of.
No.
And so they had had a lot of bad luck with travelers coming
Mm-hmm.
into the OR there because I don't know how many different surgeons and how many different procedures we do just about everything. And they just fell in love with her.
Mm-hmm.
She came in and she just immediately, they just said she's the best traveler we've ever seen come through here. And these guys have been there at this account over 45 years. They've had this account.
That's a
So,
long time.
so when I came up with this idea and started thinking of who could be involved, Aaron popped into my head one day, and the rest is history. Here she is, and I think you're going to really find that she has a lot of brings a lot to the table with her experience and her professionalism and her knowledge of things. It's going to be eye-opening, I think.
I think so.
So,
I think so too. Like I said, I think it's great that you. This was a really smart idea, and I'm glad that Aaron. I really appreciate the fact we all do that you were willing to take time out of your busy schedule to do this. So we really appreciate you. So welcome again to both of you, and John, thank you for putting this together. So, we could go either way. I guess this can go to horror stories, and this could go the way of I guess you know, roses. I don't know.
Yeah.
well, let's start it off and start the conversation because the reason I came up with the idea is so many different things, but really the first thing that strikes you as a traveler, one of the first things is that we come in to hospitals and we're basically forced to use a circuit and equipment and basically a circuit and a design circuit that we've had absolutely no say so in whatsoever. And we're not going to have any say so in that circuit
Mm-hmm.
whatsoever. And
Mm-hmm.
as you know, there's as many different circuits and ways of doing things as there are, people out there doing it.
Mm-hmm.
And it's just interesting that you're there for usually a short period of time. So you're not going to come in and start making changes. Probably the worst thing you can do. And sometimes, maybe more often than not, and Aaron can probably speak to this, that you're really forced to do things you really, really wish you weren't doing. And I'm not saying they're very bad or dangerous, but they're awkward or uncomfortable. And usually there's an element of cumbersomeness to it. And sometimes it is dangerous and sometimes it makes problem solving difficult. I would say almost always it makes problem solving difficult. And then the other reason that I thought of this idea is what you were touching on a minute ago, Joe, about coming into a new place and how they treat you. Because I call it, you're not a new perfusionist, but you're new to them syndrome. You know what I
Mm-hmm.
mean? So
Yes.
you can come in and be just the greatest thing. And I saw this happen to a guy who was 35 years experience, was a chief at a major pediatric hospital. This guy had done it all. And he came into a hospital, little account, just took it over for a group I was with years ago. And they ended up kicking him out. They ended up firing him and all this kind of stuff because of something communication with personality and some other things. And they just thought this guy was just not even qualified to do his job. Meanwhile, he was a super guy, and he still is. You have to prove yourself all over again. And imagine starting a new job, every other week or something like that, where you don't know where anything is. The people don't know you. You don't know them. You don't know where, all the ins and outs of the little quirks of the paperwork and what people prefer to do. And so it's very challenging, I think, to be a traveler. Now, after a while, sometimes you can go back to the same places over and over. I think the challenge is still there, but they get a little easier. So those are the two reasons that I kind of thought of this for people who don't go out and do this to themselves by going into a new place and trying to tackle whatever comes. Maybe there's some value to be learned. And I know, Mike, you've got a ton of things that you've done. So, and Joe's been around forever. So I
Right.
think we have a good group of four people here to talk about this.
So, Aaron, what would you say how would you open this up? So we've got John's perspective. I'm kind of curious for your perspective. I'm going to give my perspective too, but you get to be next because you're both on Skype. It's just a new rule.
Okay, that's fine. Can you guys hear me okay?
Yeah, we can hear you fine.
Okay, wonderful. I think John, everything he said is a valid point that you face if you're a local traveler, like Mike there, or if you're traveling nationally. I find that your power lies as a traveler in adaptability. And if you see something you like, kudos. Pick it up, embrace it, and be thankful that you had the exposure. If you see something you don't like, you can go ahead and go forward, outside of that account and just know what you would never bring into your practice. I think it's a privilege to be a traveler. I think a lot of people don't get the exposure, and perfusion is such a diverse field. There's 1,000 ways to do what we do, and a lot of smart people from diverse backgrounds. And I enjoy learning their approach to things, and even seeing different surgical approaches of the surgeons. I'm to the point now I can almost tell where the surgeons have trained. Oh, that's the Emory thought. Oh, that's the Texas. Oh, that's the Cleveland Clinic. Oh, that's and you learn from all of them. And I feel that as a traveler, I bring so much to the table, even to the surgeons that are there, as far as a different approach to something or how to consider, or if it comes up in conversation, discussing with them. I think it's expanding the field. And like I said, I'm a lifetime learner, and I just love traveling. It keeps you on your toes, and it's so rewarding.
That's very good. That's interesting. I've got a lot of, I have a ton of questions for both of you. But before we get to that, how about you talk about your experience? Open this up.
I think that it is something that a perfusionist tends to do earlier in their career, rather as opposed to later. A lot of times people use the traveling as a place to find that final resting spot, and hopefully they can find something they really like and stay there for many, many years. I know a lot of people have worked that way. I think it's a special person that wants to be a traveler and a special person that can do it. I believe you have to be knowledgeable, gregarious, communicative, and takes a lot more I think, to be a traveler than to be a, quote, one horse, one trick pony place. By looking back, and we said earlier, I've probably done cases in 12 to 15 different hospitals in Houston. And I was trying to sit down last night and think of all the other places that I've been, and there's been about another 12 that I could think of that I did traveling at. And the things that Aaron said are really, really true. One of the great things about it that I did enjoy doing it when I did it was that all the new things that I learned. There's 1,000 ways to skin a cat, and you learned how to get out there and say, I really like that. That's something I'd never seen before. I'd like to do that, and go from there. After a while, though, I really feel like, and I'll go back to my first statement, I think it is something that tend to be younger perfusionists that really like to do that. I think as you get older, you get to the point where you're saying, I want to finish off my career never having harmed anybody. The medical creed is, the first thing on there, the medical creed is, do no harm.
Yeah, I've come pretty close.
And I think it's a real challenge to get out there. I think back when I started doing traveling, circuits were probably, as John alluded to earlier, a lot of different ones, but they seem to be more simplistic. We do so many more things these days as a perfusionist. And so now doing it, I think it really takes a person who's not only knowledgeable, but has a lot of confidence in themselves.
Yes, and
Yeah.
yes. So those are also good thoughts. And so I'm gonna, instead of saying there's 1,000 ways to run the pump or whatever, in this case the pump, there's actually 4,300 ways.
Yes.
Because we all think our
Right.
way is the best.
Yes, we do.
And there's not any two of us that are identical.
No.
I can just guarantee you. So I had done some traveling too. Some of it was just secondary to moving, and I did a lot of that. And I've been to, man, I don't even know how many hospitals I've been to, but it's a bunch. It's a lot.
Yeah.
I don't think I have that adaptability today at all. And I think that I have some, I mean, I think John brought it up that it's a little bit fumbly, a little, unnerving. You may not be that comfortable with what's going on in that location, but you have a real, true emergency in front of you.
Right.
And yeah, we're paid to do no harm. That's true as our first credo, but at the same time, you're creating an environment where the likelihood of that occurring is much higher.
Right.
And even in the best of circumstances, and I've had four events. In fact, I think, let me see. Let me go here for 1 second. I'm doing, yes, on Thursday, March 12th, I'm going to be giving a talk, The Cases I Wish I Could Forget, Learning from Our Mistakes. So I have four cases, where just by the grace of God, had nothing to do with my skill at all. Somehow the patient didn't die, but they really should have.
Right.
Four of them. I got four of them. They are indelibly impregnated into my memory. It's never leaving.
Right.
And so, and that was under the best of circumstances. Those were places where I was comfortable. And of course, then I guess you could become too comfortable and complacent. That could be a separate issue.
Right.
But Aaron, I'm curious. When you go to a new place, obviously you have to be able to read the room, right? You got to be able to figure out, is this a positive vibe, a negative vibe, a hostile vibe, a depressed, sad vibe, all the various different things. Who's the power broker in the room, in the nursing scrub, relationship.
Right.
Then you have to say something to the surgeon you've never worked with before, and you're going to be doing this case. There's going to be that first case. Hopefully it's not the emergency case, but how do you do that? How do you go from getting off of an airplane or parking your car to a place that you have no idea where to park, to in the door and maybe not doing a case immediately, but getting yourself prepared to do a case maybe that next day?
These are the things of nightmares, and I often have these nightmares that I show up for an assignment, and in my dreams it's 2 hours later and I never make it to the OR.
Oh, God.
Because it's very nerve-wracking. So I just keep good notes. I always travel with a notebook and write everything down. Before I go somewhere, I get a contact. I introduce myself the day before, the evening before, get landmarks where I need to go, and I have a pretty good sense of direction, which is good. I think, hospitals pretty much have everything you need. Most hospitals, if I'm stuck there, I can always find a shower and a toothbrush and, a few extra sheets or something. But the important thing is first impressions. I think it's always good to respect everybody when you walk in the room. It's not always based on who you think is going to be the queen bee or the power person in the room. So I normally am quiet and observant, and my hands at my side, good posture, just trying to make a good first impression. And I take a notebook with me everywhere, and I write notes. And if someone's telling me something, I explain to them, wow, this is wonderful stuff. I'm sorry if you don't mind. I'm going to write this down. And I keep my notebook with me everywhere. And outside of that, I just you don't go in with a strong personality. I don't. I go in with just, I'm here to help. How can I help you? And that tends to be my token statement. I'm here to help. How can I help you? And sometimes they pay me to come in and stock their shelves. Sometimes they come in and I'm crashing on bypass and can't find a syringe and don't know where the medications are, and I'm asking for all emergency supplies. And once I get oriented and up and running, I keep bags of things for those emergency situations. If I was military, it'd probably be called an oh crap bag. But I have whatever.
Everybody thinks that their internet went down,
Yeah.
more than likely. We're up, we're back live. Okay, so if anybody was there that was watching, please forgive the mishap, but we had a technical difficulty, and we're back online now. So, Aaron, I'm sorry, you were talking about how you go into the room, you basically very softly, unalarming, or just sort of, you're there. You how can I help you? You mentioned that sometimes they just ask you to stock their shelves. They're paying you, so they want to get some work out of you. I'm assuming that's why they do that. But then you talked about the crashing emergency, and you have nothing, and you don't know where anything is. So that's where you left off. Go ahead and take it from there.
Yeah. So from there, what do? You just that's when you rely on communication. So I've had to explain to team members that I'm gonna communicate effectively. Everything you say to me, I'm gonna repeat back to you. If you don't hear me repeat what you're telling me, I do not hear you. And we're kind of gonna be on belay here, because in those scenarios, there's 10 people talking. And if they don't recognize my voice because I'm the newbie in the room, then I want them to understand I'm not ignoring them. I hear them, or I don't hear them.
Right. Well, I'm a big believer in that.
I feel like that bridges a lot of gaps in those horrific situations.
Yes. Well, I'm a big believer in that too. I think, and I'm a pilot, so I fly, and I know a lot of people that say perfusion and flying, it's not really the same or whatever, and they're right, it's not. It isn't the same. But what is, I think, what we can learn from aviation, and there are several things we can learn from them, but this one is when air traffic control gives me instructions, they expect me to read those instructions back to them. And then they'll tell me the readback was correct. Or they'll say, no, do this. So there's that two-way communication. And when you don't have, when it's assumed you heard, or it's assumed they heard you, and it's not, it can be very problematic. It's dangerous.
Yes.
Yeah. So if you haven't been able to tell, see, I can tell, I think you can too, her personality. It's very unassuming. You smile, all of that. I mean, it's really perfect for that role. Me, I walk into someplace new. Look, everybody knows I'm there, all right? And that's just me. And so traveling for me, I think it'd be hit and miss. It'd be hit and miss. If it was any place that, and I'm polarizing. You either love me or you hate me. There's nobody that just says you can take me or leave me. So that's the next problem that I have. And they're saying stuff back there too, and I heard it. But anyway, with that said, John, you were going to ask something?
Yeah, so I was at an account, and this is a very substantial account. Went in there, and I love the circuit. I actually knew the guys from many, many years before. Very experienced perfusionist, and nice setup, simple circuit. Everything made sense. And I said, so and so, anything I need to know here, like you can think of? And he says, Well, he says when they connect the arterial line to the cannula, he says you're going to do it. I said, what do you mean I'm going to do it? He goes, he's going to pass it off to you, and you're going to connect the aortic cannula to the aortic line. I said, I have no idea what you're talking about. So what they do, and maybe you guys have seen this, they add about a 4 foot piece of free 3/8 tubing to the aortic cannula. They prime it up and clamp it and hand you back that clamped line, and then you have to make and figure out a way to run up your oxygenator, your arterial line, and make the connection over a top of your oxygenator. You make the air-free connection, and if it has a bubble in it, you have to disconnect it and redo it. So you're doing it by yourself. So let's say you have a centrifugal pump head. You have to figure out the perfect RPMs so it slowly runs up your arterial line and connects to this, and it's a sterile connection. You have to, and almost impossible not to have some spillage down on top of the floor or on top of the oxygenator. Have you guys ever seen that?
No.
Well, no. And I would hope to. I mean, who came up with that cockamamie idea?
Well, let me tell you what Erin made me think of this, because I had forgotten about this. When she said, I can almost tell where people have been trained. Oh, that's the THI way or Cleveland Clinic way. Well, I'm not going to say, what famous place this is, but apparently that is a famous place's way of doing it that's been around a long time. You're familiar with that, Erin? Have you seen that?
Thank goodness, no.
Oh, yeah. Well, they've been doing that way for 30 or 40 years at this particular hospital, and that was something that the surgeons who trained at this place, they thought that was standard. So they would pass it back to us, and we would make the connection, and would make drips all over the oxygenator, blood on the thing, and off you would go. And yeah, I was wondering if you guys had ever seen that.
Yeah, that's crazy. No. Hey, John, the guys are asking me, can you move like an inch or two to your right and back up just a teeny little bit?
How about that?
That's perfect.
Okay.
Yes, they're giving me the thumbs up. Good. So yeah, that's crazy. I mean, I've seen some stuff. I've seen some really crazy stuff.
That's pretty crazy.
This one might this might top it.
Well, the interesting thing is that all these surgeons have been there for a long time. The perfusionists have been there for a long time. They thought I was strange for not having seen this or been aware of it.
That brings up yet another point. I'm glad you said that.
And they forget that maybe this is really not how the real world does it. And I'll bring another thing up that Erin was sort of reminding me too. I went and worked at a place for 3 weeks. I did a 3-week vacation coverage. It was a single person account, and it was a very small town and a very small account. I don't think they did more than about 60 cases a year. And get this, Joe, the surgeon was completely off pump. So the perfusionist did 60 cases a year. 90% of the cabbages were off pump. The only ones that were on pump were as if it was a very difficult case, or it was in a crashing case from the cath lab, or it was a valve. That was the only pump cases that he did the whole year. Anyway, I go there for 3 weeks. We did one case. We did a triple valve cabbage times 5. Never been done at that hospital before.
What? Wait a minute. Wait a minute.
Yep.
They do 60
before.
cases.
We were on pump 6 hours, 5 hours and 5 minutes cross clamp. And believe it or not, the patient came off and did fine without a balloon pump. And here it is. Now understand something. I had never used this circuit before. I'd never met a person in the room before, because when I went there the day before he went on vacation, he took me into the OR. It was a Saturday. There was obviously nothing going on. He had a circuit set up, and he had a second backup pump. And he said, well, if you want to familiarize yourself with the pump, you can set up that second pump by looking at the first one, which is what I did. And the case came up, and I called him on the phone a couple times with a couple little questions, because he had a very old computer-based screen that I've never seen since, that kind of did certain things with his pump. But yeah, I mean, that he was telling me, that they don't even do anything there. And so lo and behold, they had this case, and I had never met a single person in the room, never didn't know anybody's name. They didn't know me. And fortunately, everything went well, but it could have easily, something, we did have a little bit of a mishap. I won't go into it. It's a little hard to describe with, when he made the connection to the arterial cannula, blood was coming back towards the pump as if I had the clamp off or had the occlusion loose on the roller head, and none of those things were true. And it just turned out that he had some strange line coming off the arterial line filter that looked clamped but wasn't, and ended up being allowing blood to come back towards the pump. But anyway, once I got that figured out, that was just the strangest thing that happened. And I don't know, Aaron, have you ever had something like that happen to you?
Yeah, I went in somewhere and I was told that they don't do retrocerebral, they don't do dissections, they don't do in here. I'm doing a retrocerebral dissection with a roller pump, with no idea what the cannulas are or whatever. And they come back the next week and they asked how it went, and I told them the case I did, and the chief looked right in my eyes and said, "Oh, we don't do that here." And I was like, "Well, actually, you do that. I did that here. Like, we did that case here." He's like, "No, we don't do that."
Oh my goodness.
And he insisted that you didn't do the case. He kept
insisted, yeah,
no,
he
you
kept.
couldn't have done that. And you're like, yes,
Yeah.
we did do that.
I
No,
said, I just did that Saturday night around midnight here at your hospital with your surgeon, and
Oh my God.
he's like, "Well, I wouldn't even know how to do that. Like, well, what would you use?" And so I just had to kind of come up with a game plan with the surgeon and figure it out, and get everything set up, and what else are you gonna do?
But again, I think that going to my earlier point is that the surgeon has to be receptive to you going up to them and saying, "What's our game plan here?"
Yes.
And if they look like they are deers in the headlight and they don't know what to do at all, because they don't do that procedure or whatever it is, and you're fixing to do it, I mean, this brings up yet a different question. What is our responsibility when we are confronted with a situation where we think what someone else is fixing to do to the patient, that we are there to help and facilitate? When do we say, "I'm not going to do this"? Has that, John, has that ever happened to you? And then Aaron, I'll ask you the same question.
Where I've actually said to someone, "I'm not doing that."
Yeah.
I have not had that happen, but I do know of a situation where there was a Jehovah's Witness patient, and the surgeon came up to the perfusionist and said, "I don't care what the patient signed off on. We're giving this patient blood." The patient had signed everything possible that no matter what, he did not want blood, and the surgeon just flat said, "I don't care," and they give the patient blood. So if I had worked at a place like that, and I would tell that surgeon, "I'm not doing your cases." I mean, I've done things like that where if you're going to do something that is so egregious that everybody in the room is likely to get into a lot of problem with this, I would tell the surgeon that you're going to have to find somebody else to pump your case if you're going to do that. I can't think of a case where I personally told a surgeon that I'm not doing that case off the top of my head.
Yeah.
I'll give it some thought.
Aaron, you have any thoughts?
Go ahead.
No, go ahead. I'm sorry.
No, I was just at a very small account going for bedside ECMO coverage. It was very long shift, 20 some hours.
Oh my God.
And the surgeon had the ECMO that I had been assigned to take care of transferred out. No big problem. But there was another patient that she felt like was trending downward and should go on ECMO. and was very stable, not a crash and burn case. It would have been VV. And I had no badge. I didn't even know where the operating room was. I had 2 clamps. I had no supplies, and she wanted to call somebody to bring me everything to the bedside of a new patient. And in this state, I'm licensed. So, I have to consider, is this worth my license, to do? And she wanted me to help her put another patient on ECMO. There wasn't an extra circuit primed or any supplies to do that around, because the on-call perfusionist at the hospital was not answering the phone.
Oh, the not answering the phone trick. We all know that trick.
So
Yes, we do.
I just had to politely decline it and just, explain to the surgeon that I would give my best and do my best, and I probably could do it. However, I feel the quality of care for that patient would have been exponentially better if there happened to be a mishap during the process. We cannulate, then you can't flow, or, whoever, how all things can go wrong when you're fem-fem cannulation. That I think that they should wait and have the on-call perfusionist come in who has access to all the supplies and knows where everything is and seconds of everything and has a badge. So
Absolutely.
I just said I believe that the quality of care would not be to the level that patient deserved.
Right, and you made that Now, let me ask you this. How did the surgeon respond to that?
A little quiet at first, and then kind of came around. And again, this patient was not crashing and burning.
Right.
This patient the blood gases were trending downward. There was no hurry to do anything, and
They weren't going to die of. They weren't going to die of anoxic brain injury.
Right, absolutely not. And so she did, agree. And I did bring up the fact that, I'm licensed in this state. And if something unplanned were to happen, I would be torn about it if I would lose my license over this.
Potentially.
Yeah. And I told her, I said, I don't think it's a risk the patient or myself should have to take in the current situation. And the surgeon agreed.
Well, that's good. I'm glad that they did come around to understand that. And actually, we say we don't want to lose our license, but really, you don't want to hurt the patient.
Right.
That's really the issue here. The issue is not that I'll lose my license. The issue is that you would lose your license because you would deserve to, because you did not look out for the best interest of the patient. And we all have that responsibility. You, me, you go into a hospital and you're doing anything. Watching an ECMO, doesn't matter, inserting an ECMO, doing a case, standing by, whatever it is. Everyone in that room, from the surgeon, anesthesiologist, nurses, surgical assistants or scrub techs, whatever the preferred term is for them, perfusionists, anesthesia tech, everybody is supposed to be a patient advocate. Everybody. And that's something that's very important.
And I think in that scenario, I had already kind of proven my knowledge base because we had transported the patient to CT. It was the first time that hospital had ever done anything like that. So with my experience, I became the expert.
That's good.
On the team.
Yeah, that's helpful.
And so I was able, throughout the process, that I was there for over 24 hours, they were able to see, okay, she knows what she's talking about. She probably can, but yeah, let's put the patient first here.
Absolutely. Mike, you got any good stories?
Oh yeah, there's we were talking about
and specifically referring to, let's ask the question, have you ever said, I'm not going to do this case because of who the surgeon was?
I don't think that has ever come up. I've been fortunate that it never has, but should it still have a few more years left, I would certainly, especially at this point in my career, I would say, no, I am not doing this, because I do know that this is not advantageous for the patient, and I refuse. I refuse to do the case. Never had before, but doesn't mean it still won't come up.
I came real close right here in town.
Did you?
I came real close.
Yeah.
Real close, and I was counseled not to,
Yeah.
because it would obviously be a big problem. But I know you know what I'm talking about, and but I was like, I was ready to say none of us were going to, none of us,
Right.
and I was on the verge of doing that, and I didn't have to because, something else happened.
Right.
So it really became an inconsequential thing. So where'd they all go? Oh, there they are. Oh. Oh.
So Joe,
lost you.
on a little bit lighter note, and Aaron has this same nightmare that happened to me, and this is so simple, but not something that you would think about. Now, this is a hospital that I go to fairly routinely, and normally I'll work an ECMO shift, 7 p.m. to 7 a.m., and I go right in, and I know exactly where I'm going. I go right in the main lobby, first elevator, up the third floor, whatever, and I'm there. Well, one day I was running a little bit late, and I got there about, 3 or 4 minutes after 8 o'clock. They lock every door in the hospital at 8 o'clock.
Oh, God.
And you have to go find the patient entrance to the emergency room.
Oh, God.
Now, I don't even know where that is. I've already parked my car, and I'm walking to try to find the other side of the building at night in the cold for the patient entrance to the emergency room. And when I get to the patient entrance to the emergency room, I don't know how to get back to where I'm supposed to go, because I knew how to get in the easy way.
You knew one way in, one way out.
You know,
Breadcrumbs.
of course, I ask and I get there, and you have to survive. You learn to be survivalist real quick. But if that had been an emergency case that I was running in for, that probably cost me 5 or 10 minutes, but it probably feels like a lot longer. And the stress involved, it's unnecessary stress. But when people bring you into an account, they can't think of all the little nuances and mishaps, because they have a badge and they go in through some back employee entrance. They never face this.
Right.
And they're not going to face it. So they
Right.
don't think to tell you things that could go wrong. They tell you what you need to do. We chart, we do this, we do that. Every 4 hours we do, but nobody thinks, well, what if I can't even get here in the first place, right? And here it is, everybody's wondering, where I am and everything. So sometimes before you even get to your job, you've already had some, stress that you've had to deal with, and you just don't know. I mean, I would have never thought they locked the door at 8 o'clock. I think 9 o'clock or 10, but I guess some places are gotten earlier, and just completely threw me for a loop. I was no problem going to that hospital all those times before that.
That is horrible. So John, you brought this up, and I wanted to sort of go a little farther with it, and that is thinking that the people that were doing that with the arterial line, like connecting the line to the cannula, and they thought you were strange because you had never seen or heard of that. And so it kind of, for me at least, brought up some thoughts of how deep in silos are we? And how can somebody, and I'm assuming they were seasoned perfusionists, right, Aaron? They've been practicing for a while. How do they not know that that's not common? I mean, if you finish school, go to one place, stay there for the entirety of your career, never go anywhere else.
I call that institutionalized.
Institutionalized, yes. And
That's the way we've always done it.
right,
Yeah.
exactly. Well,
That's
it's
the way
like,
we've always done it.
it's one of my favorite sayings. Do you know there's a saying? And anybody out there, if you know it, say it. You'll win a prize if you know it. You get a cup. Perf Whip cup. These are valuable. They're collector's items. There's one phrase that answers all unanswered questions in the universe. Do you know what it is?
That's just the way we do it.
It's just the way it is. You were close.
That's the way it is.
You were close, but I'm gonna give you a Perf Web cup because that was close. The way it's just the way it is.
Yeah.
It's the way it is. The way it is. That answers everything. Why do you do that the way it is? That's it.
Makes it easy.
Yeah.
Makes it real easy.
It solves every problem that there ever was. So that's something that concerns me, that we have a profession of which we are one of the smallest fraternities out there. 4,300 plus or minus, give or take. That is not a lot of people. Now, we're not quite as small as, let's say, astronauts that went to the moon. That's a smaller group. But we're still a pretty small group for a medical profession, for a profession, a dedicated profession at that. How do we not, I guess, expect, or that people don't feel the responsibility to make sure that they learn other techniques so that they can always reflect and see if what they're doing is the right thing? That what can I do better? And maybe you can't do it. Maybe you don't see anything that looks better. You say, "Nah, I like my way better," but you don't know what you don't know, right?
Right.
And there's no way to know that. And so I think that's something. I wonder if that shouldn't be required. And I had one more question too, and this is very important. Should it be required, John and Aaron and Mike? You're doing per diem. You're doing locums. That's what you do. And they're leaving on Monday. So you get in on Saturday. And they don't want to pay you until Monday because they're leaving Monday. So they show you some stuff on Saturday. Monday morning, they're gone. You go in there, do the case. No formal introductions, no orientation, no, getting your bearings, where is everything and all that kind of thing. Never doing a case, and you're just left, assuming that, you'll do fine. I've been here all this time, but I've worked here for 20 years. It's easy, unless you're the first time there. So should it be required for locums to have in these agreements, these hospitals that hire people like you guys, that they have to bring you in a day before? So you'd come in on Thursday, they would have to pay you for Friday or whatever day it is that even if you have to fly there and fly back and then wait to go back, but at least you've gotten some level of orientation. Should that be a requirement, a standard of care? Or let's put it that way, a standard.
I think of the way the current state is if you're the traveler and you insist on that rule. I don't know that there's any rule out there that anybody's going by, but if you're the traveler and you insist on that rule, then it could be whether or not you go there or not. I think most places when you pump cases, they want to do that, but there's so many small accounts out there that do one case a week. There's a lot of accounts that only do 50 to 80 a year, and you might go there and they might not do a case for a week or two. Well, that guy or girl is going on vacation in a couple days. So they just show you everything they can show you, and then you hope that, you have their cell number. It's kind of the way it works out. If it's a busy place and they're doing cases, I think they always try to get you to watch maybe even more than one if they can, and get your hands on it a little bit with somebody there as well until they put you on your own. But if you're taking over and it's a one-person account, you just might not have that luxury.
Yeah, I think, well, yeah, so, of course, I'm assuming the hospitals would be somewhat resistant because that's going to cost them more money. I don't know. Aaron, what do you think? Aaron?
Okay, sorry, you guys. I I guess I can start with the second question about being brought in one day before
Mm-hmm.
or a little bit before. I think that the norm is for you to be oriented.
Mm-hmm.
Even if it is a quick orientation, I think the camaraderie in our small niche, I think most people don't want to burn you. And I think if it's a one person account, and I've been to several of those, um, they're nervous about leaving. This is their baby, and they're tied here 24/7 on call, and they don't want something bad to happen when they leave because then they can never leave.
Yeah, that
You
makes
know,
sense. I
they'll
mean, that
never
of
get
course
out
that
of
makes
there.
sense.
So, I
Imagine.
find that for the last 3 years, I have been brought in a day ahead of time, 2 days ahead of time, and had a chance to put my hands on everything and look at everything. I have a lot more experience with that than I do those nightmare things where you're coming in and crashing on bypass, and never been to the place. That has happened, but
Mm-hmm.
Mm-hmm.
that is my exception.
Mm-hmm. Yeah.
In
I,
my experience,
mm-hmm.
there's fewer of those experiences than I have of actually good experiences of coming in and getting a decent orientation. And I offer to people, if they don't have anything in writing, I'll talk with the person and I'll type up
Mm-hmm.
something, case logistics, how do they expect you to hand off? What does anesthesia expect you to do for autologous donation? What is expected of point of care testing? And I write it all up beforehand, and I'll ask them to review it when they leave if they don't have anything like that. And then I leave it for them
Mm-hmm.
so I can make the next traveler going in and out of there, their role easier.
Mm-hmm.
Mm-hmm.
I try to strengthen that camaraderie and, use that lifetime learning
Mm-hmm.
to help the next person that comes along. Because there are times you go in somewhere and there's nothing written down.
Mm-hmm.
So
Mm-hmm.
Mm-hmm.
Hey,
Very
hey,
good.
Joe.
Okay,
I,
so let's do this. So I've been asked if we could can we take a 5-minute break? So everybody that's out there, we're going to take 5 minutes. I think they're going to probably kill our mics. So you guys can take a break too, and then we'll pick this back up again and go from there. But I just want to say very quickly, I'm glad you said everything you just said, Aaron, because at first I was sort of like, man, this sounds just crazy. I don't know, if doing that makes sense. But you're saying that it's really pretty structured.
yeah, if you allow it to be and you make it be, I feel like it can be pretty structured, yes.
I like that. Okay, 5 minutes. We'll be right back in 5 minutes. Okay, and welcome back, everybody. We have Aaron and John still with us.
Here.
Let's see, where'd they go? There they are. Hey guys. Okay, so no, that was really rewarding to hear, Aaron, because I come from a time, the traveling that I did was years and years ago.
Mm-hmm.
And we were cowboys. We would do that. But I also think that when we did that back then, everything was not nearly as complex
Mm-hmm.
as it has become. The whole thing it was pretty simple.
Mm-hmm.
It was blood in, blood out, and that was it. Blue blood to red. And we didn't have all this other stuff. It was one way of giving cardioplegia if you gave it at all.
Mm-hmm.
There was, just a venous line, arterial line, you do this, you do that, and you're done.
Mm-hmm.
And that was it. So it was a different environment. But now with the complexity of everything and the point of care lab testing and the required documentation and the, just the stuff that you have to do, and the pumps are, they're computerized. I mean, we had an on and an off switch,
Mm-hmm.
forward and reverse.
Mm-hmm.
I mean, that was it. It was very simple. But you were saying that in your experiences, you were saying about how it's been for you, and you had one place that had everything. You met with them and stuff. You want to tell that story?
During the break, I was speaking to Joe, and of the 12 or so places that I did relief work in, it ran the gamut as to the information you received on how to run an appropriate case in that institution. Went from anything from, oh, this, it's real easy, it's yada, 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 and you can just get it done real easily, where I had to ask most of the questions to make sure I felt comfortable with what I was going to be doing. Whereas at the other extreme, there was a lady that I relieved who had everything scripted out like a Hollywood movie. It was amazing. She had all the physician preference lists, what they did. If she mentioned arterial cannula, she would tell you the words that he would use to have you run up the volume and make the connection. And it was like a 10-page script for her normal, straightforward cab. And of course, I was so appreciative of that. I told her that everybody should adopt that, that she should make that as a, quote, generic script for any company that wanted to come in and give her a break, because I felt like a perfusion student could have walked in on day one, graduate perfusion student, and could have done her case because it was so well lined out.
Mm-hmm. That's nice. That's nice to hear too. That's nice to hear too. I'm very disorganized, and no one would ever want to come relieve me. But you know, that of course brings up, you know, other questions. Should there be solo perfusion accounts? Should that even be permissible?
Well, that kind of ties back into the first question before the break. You were talking about really how independent we are. And, you know, if you remember the first question, I forget exactly your words, but pretty much, you know, we do so much on our own. Should we know what other people are doing at other institutions as far as cannulation techniques and I think that, as I've found through my travels, and I've only been doing this 12 years, so I really pale in comparison to you guys. And I appreciate all your years. I feel like you're considered strong when you don't need help in our field.
Mm-hmm. Mm-hmm. That's a good. Now that's a good point. That's wrong-headed, but true.
And I run into that culture a lot when I'm on the road. And it's even in new grads, I see it. And it's in people who are nearing retirement. And I think because we're so independent and all of our responsibilities and roles, we have a very small niche and we're great technicians, that it's hard for us sometimes to take the help. I always take help. If I'm at an account and someone wants to be in the room with me, I get excited about that because I'm always alone. Mm-hmm. You know, I'm always doing things alone. You know, there are several accounts I go to where 2 perfusionists are assigned per case.
Mm-hmm. Now, I think that's a bit much. John, you were going to say something?
There's 3 states. I don't know the exact states, but I've been told by someone who would definitely know recently. There's 3 states that it's required to have two perfusionists on the pump. Mm-hmm. And I could see why people could think that is an insane thing to do, is to be the only perfusionist at your account. And I know some very powerful, wise people in our field, Joe, that have been around forever and kind of the leaders of our field. Some of them would be very, very opposed to ever being the only perfusionist at your account. And a funny thing is, I've actually done that probably about 15 or 16 years of my career here and there. I was the only perfusionist at my account. And I suppose it's pretty lucky that, you know, but I had many, many instances where I was either ill or was stuck in the room for 8 or 12 hours, and you can't get a drink of water, food, or go to the bathroom. And there is nobody to call. You know, there is nobody to call. And I could see why people could make that argument. But I wanted to say about a circuit situation that I had to pump a case that it was dangerous and they were not going to change it. And I wanted to, not to shift gears too much, but it's one that occurred to me while you guys were talking earlier. Have you guys ever seen where when the case is over and you're off pump, the very second they're pulling the cannulas out of the heart, the surgeon has them in his hand, connected to your tubing, and hands them to you, passes them off the table.
Oh, I've got a great story for you. Yes, I have seen that
Yeah,
happen.
I've seen it.
Yeah.
And
I've seen that.
yep, I've seen it happen. So
Okay,
great,
'cause
great question.
This place I went, I mean, I had never seen this before. I mean, the case is literally minutes you're off pump, and the venous cannula comes out. That's fine. Give a little volume, and then bam, he's handing you. The surgeon hands you the lines, and you better have a way to grab them because he's handing them to you. Now you haven't even gotten all the blood out of your circuit over to the cell saver yet, and so you've got the tips of the cannula in a red bag while you're trying to get the circuit blood to the cell saver. And if the patient crashes, so this place had been doing this for many decades, and the perfusionists had been there. And I asked him one day, I said, haven't you ever had a problem with this where the patient, you had to go back on pump? But he goes, oh yeah, he goes, one day I had to do it 3 times. I had to set up the circuit and go back on 3 times. And I thought to myself, and I guess
Oh no.
and I guess you still didn't learn
Yeah,
because you're still doing it.
I mean,
But
why would-
that's a good.
Oh no.
Yeah, I mean, it's scary because you're new. I cannot tear this circuit down, set it up dry, and prime it nearly as quickly as you can
right.
Yeah.
because you've done it 5,000 times. I've done it 2 times. You
Right.
know what I mean?
Right.
You guys have all seen that. Did you do anything about it? I mean, we
Well,
just had
I'll
to live
tell
with
you.
it, right?
I'll tell you the story, and I'm trying to remember the guy's name. Let me think about it for a minute. Oh man, he was the author of the Sugar Busters book, or one of the authors of that book. I can't remember his name to save my life, though. But anyway, so it was in New Orleans, and I had just changed jobs from one company that was covering University Hospital and went over to the company that was covering Tulane that also had these other accounts in the city. So I was sent over there, and there was somebody else there, so it wasn't even going to be by myself. And man, I wish I could remember that guy's name. But anyway, so the guy that was over there, though, was really, really, really weak. In fact, he's not even a perfusionist anymore. He was really, really, really weak. So I was going to do the case. So I went on pump, did the case, come off pump, same thing happened. Comes off pump, and I was just sort of trying to get my bearings, and I can see this hand and a line in it shaking it at me like this. And I was kind of clamped, so I was crouched down, and I looked up and I said, what do you want me to do? And he said, take the line. So I'm like, okay. So I grabbed a clamp off the thing, the mast,
Yep.
opened it up, took it, he let it go, whipped around, and I put it up here. The next thing I know, here comes the other line. So I'm like, well, this is a new one on me. Okay, this just doesn't make any sense at all.
Yeah.
And I'm just this had never happened to me before. And I was probably I'd probably been doing this for about 25 years at the time. So I had some years on me, and I had never seen it. I'd been a lot of places. So I took that line too and hooked it up on the thing. The other guy had wandered off. So I'm there by myself. Okay, keep that in mind. So I'm like, that was the strangest little event that I think I've ever seen. And this guy was just so nasty. I mean, he was mean, but only to me,
You're the
not
newbie,
everybody
yeah.
else in the room. Everybody else in the room were wonderful. I was being treated like a dog with mange.
You were the whipping boy.
Bad,
Yeah.
big time. So the case gets done, and I waited, and he came and he was walking to get ready to walk out, and I kind of got in his way, and I put my hand out, and I said, it was very nice having met you. I wish you the best of luck in the future. and he's just standing there looking at me, not shaking my hand. I've got my hand out, but he's not shaking it. And he's like, what the hell are you talking about? I said, I want to say that pleasure to have met you, and I wish you the best of luck in the future. He says, what are you talking about? We have another case. And I said, no, you have another case. I am never doing another case for you or in this hospital ever again. I'm leaving. Best of luck to you. And he just blew past me and stormed out the door. I never went back. I left.
Yeah.
And I didn't only just leave. When I walked out, I finally saw the guy, and I was like, dude, that pump needs to be torn down. He goes, oh, well, I'll help you. I said, no, you don't understand. I'm leaving. I quit. Okay, I quit. You understand? Quit. You go clean that mess up, set it back up. You have another case. I don't. Bye. And the company didn't fire me. I didn't actually have to quit. They didn't fire me because they were so desperate for people, and I was like scraping the bottom of the barrel. But yeah, so that was my experience, and it's killing me that I can't remember the guy's name.
Well, I have a question for you guys. In that case, it sounds like you've all seen it. What is the mindset? Where is the advantage? In other words, when you do something, any technique at all, I would think that you have a mindset that, hey, this is a good idea because. But
Yes,
I
agree with you. Why would you do that?
Why are you doing it? Like, what is this better than what you were doing when you didn't do this? When you left the lines up until, a reasonable amount of time? How did this suddenly become, more intelligent than the counter?
I don't know, dude. I don't know. People, I have traveled around a lot, and I've seen some strange, ways of doing things. Like I was at one hospital where it was with I had this company, and they needed some emergency help. They had a big mess on their hands, and I went up there, and that's when we had Brent, and Brent went up there, and the other guy, Mark,
Right.
and he went up there, and they had this pump. The way their pump was set up, they had all of these lines that were connected, like recirc lines, that you had to access in various different times, the way they did their cases, but they were all on the other side of the pump, and there was no way to access it without going on the other side of the pump to do it. And I'm like, of course, I'm just sitting there thinking to myself, thank God I don't have to be here to do these cases. I was leaving 2 other people to do it because I was like, I don't want to do this. This does not look good. And this was a big place. This wasn't some little place. Big. Lots and lots and lots of cases. And they just had the craziest pump circuit I've ever seen. And to your point, John, what is the advantage of getting rid of the lines other than putting the patient at increased risk? Did you ever say anything like, why do you do this? Did you ask?
I asked the chief, I said, haven't you ever had a problem doing this?
Right, and he did
And
3
he
times.
told me, well, yeah, one day. But as far as why, that's the surgeons were trained that way at the blah, blah place that they trained.
Mm-hmm. And so did you not feel comfortable to go up to them and say, why do you do this? This is the upside. The downside to what you're doing is this. The upside is that.
Yeah, I think as a traveler, you walk a very fine line. Aaron probably has seen this more than me.
Yep.
There are travelers out there. The ones that succeed have to be chameleons. You unfortunately have to do, like I said when I opened up the conversation, a lot of things that you just wish you weren't doing. And then if you go in, and there are people who do this, they go in and they start, you shouldn't be doing this, and I'm not doing that, and I'm going to do it this way. And, that's kind of professional suicide as a traveler, I think. I don't know how you ever get called back And after a while, I don't know who's going to call you. But there are people that do that, right, Aaron? You've seen that?
Yes.
What's the outcome eventually?
Well, yeah, they're not asked back, so they just keep on their journey, but they're not going back. They're always at a new place.
Well, we had one come through where I'm at about a year ago, and they just fired her over a text. They just
What?
texted her, "Don't come back."
Oh, the traveler.
Yeah, yeah, because she
Yeah.
was helping out, and they just texted her. They didn't even bother, sitting down and talking with her. That she made a huge, gigantic scene, and it was for no reason whatsoever that I could figure out or anybody else could figure out. But she thought it was important, and they just texted her and said, "We don't need you anymore. Don't come back."
Wow.
So I mean, that's one place I know she's not coming, and I have a feeling that's probably happened a lot of places. But yeah, I mean, that's one reason why I brought this topic to you, Joe. You're doing things where you have no say so in the design of the circuit, no say so in the technique. Now, once you're there a while, if you're there for a week or two or three, and you gain their respect, you can kind of start approaching things, and maybe you can tailor a couple little things while you're doing a case that make you a little comfortable, a little more comfortable. You know what I mean? And once they're not watching you as close, you can kind of say, well, I'm kind of going to leave this stopcock open, even though you guys leave it closed, and different little things that are more like style, but at least it makes you feel a little more comfortable. You can get away with, I think, after a little bit of time. But when you first come in and you start wanting to change stuff,
Yeah, I don't think you can do that either, John. I'm with you. I tried my best when I went out there to mimic exactly the way that they did it, and for me to adapt to them, not them to adapt to me. And that's why I was so insistent on knowing how things were done, so that I could. I wanted that surgeon to feel like their perfusionist never left them, that they're doing it the
Yes.
same way and they feel comfortable with it. And I guess I did pretty good because of the 12 places I went. I think the day I was leaving, the surgeon turned around and goes, "Would you like to have a job here?" So I was flattered, and I said, "Well, no, I think my wife would not." I didn't say that. My wife would not want to live here, but I was really flattered that they thought that much of it and said, "I think you and the other perfusionists would get along. I'd love to have you come work here." So I thought that was good, but. Yeah, I'm with you, John. I think that's the way you do it. You just have to mimic them and follow them as close as you possibly can. And then as time goes on and you can put your signature on a few things. And, doing the way they did it is how you learn some things, especially me as a young perfusionist out there doing relief work when I was young. That's how I learned to do things a different way. So, yeah.
And see, that goes back to that original point that I had, is that if you're institutionalized, as Aaron calls it,
Yeah.
then you don't know
Right.
what you don't know,
That's
right?
right.
You do that traveling,
Oh, yeah.
and it gives you an edge
It does.
later in your career because you learn things from other people.
Right.
And that's going full circle right back to the very beginning of this program of how do we encourage or create an environment by which people would be more aware or more informed about other ways of doing things. And even though, John, I agree with you and I agree with you too, Mike. I mean, I agree with Aaron. I agree with everybody on this, that when you go to somebody else's account, you're not there to change their account.
Right.
You're there to do, to basically act like you'd been there for 20 years.
Right.
That's the goal, and that's how everybody ends up liking you, getting along, calling you back, etc. But we all know that if you hand me those lines at this point, this is not a good idea. Because if
Right.
something happens, it's not in the best interest of the patient. So, yes, you want to keep your business. Yes, you want to not create problems. But in that circumstance, in some politically sensitive way, is there not something that you should have said? And I guess I'm kind of being a little bit, being a bit of a provocateur with you, but should you have said anything?
My first thing is to go to the chief in a calm way and try to talk about, I see you guys do this and I'm just trying to learn, and I see that you hand the lines off like 5 seconds after we come up. I try to explore a conversation, and then maybe you can find out that, well, if you don't want to do it that way, then just tell them, and they won't pass it. I mean, sometimes you strike up on something that you find out you can solve easily. But most of the time that's not going to be the case. But how would you handle that, Aaron? I don't go barking to the surgeon and to the anesthesiologist. The first thing I do is either talk to a staff perfusionist who I can confide in, and then or go directly to the chief and just try to see what I can understand about why you guys do a certain way.
Oh gosh, this is where our profession becomes a dance, right? You got to learn the dance, and I think that it's different everywhere you go. Who you feel like you can have an intellectual conversation with, who you will not offend, and probably before I would take the lines, I'd look up at the patient. Is there a swan in? What's the pressures? Ask anesthesia. Everywhere I go, I always ask if I can break down the pump. So I probably would have asked as they were handing them to me, does this mean I'm going to break down the pump now, if that's okay with you? And if they hesitate, then I think the point would be proven, and I would have asked it in a professional way and put it on their shoulders. I tell everyone everywhere I go, I take orders. I take orders, and so if you're good with this is what I'm going to do, and go from there. But it's a dance. You don't ever know where you're going into, who holds the power. You gotta learn the dance and take the lead. And I've learned to ask questions where it throws it back on them. And if they give the command, then okay.
Have you considered running for office?
I am the least political person you'll ever meet.
That may be something you need to do. You need to at least consider it. And that's probably why you and John are both successful at going out, and you were successful when you did it, and I was not. Okay? Because that's just not me. It's not my person. I know, even though I did it unsuccessfully, but I did do it. I don't have the right personality for it. I cannot do what you're doing. That's not in my DNA. I would be like, look, guys, I would have told them, you really need to keep those up there. If you hand those back to me and something goes wrong, the air bubble decides to go down your brand new LED graft for whatever reason, and we have to crash back on, I can't put this back together again. So you just got to keep them.
And as you know, this with the guy that was flicking the line at you, and the guy that he has both hands handing me the arterial and venous
I know,
line.
it catches you off guard.
Basically, the surgery has come to a stop until you take those lines from that surgeon.
Yeah.
Right? In other words, he's not doing anything. The surgery has come to a stop, and he's waiting on you to take those lines from his hands so he can go back and do what he's doing. So, yeah, I mean, are you going to have a big debate? I will tell you one thing I did many years ago. This is not as a traveler. This is the account that I worked at. And they opened up the account to all the surgeons in town could come through. So we had one surgeon, one perfusionist, me, and all of a sudden 6 to 7 different surgeons from all around the big city I was working in could all come through. And this one surgeon came through, and he was really old school. And at the hospital he was at, they'd been doing it since the 60s or 50s, and he had the same perfusionists that were OJT. He'd still been working with them 40 some years. So he comes over to this hospital, to where I'm at, and He is the kind of guy that turns around and tells the perfusionist every single knob to turn, when to turn it, how much to turn it. I mean, literally tells the perfusionist every single thing to move. So, and I wasn't prepared for this, and so he was doing this to me during the case. And about halfway through the case, I stood up and I said to him, "Doctor so and so, I went to school for this. I went to school for this. You do not have to tell me every knob to turn."
Mm-hmm.
You know, I mean, I have stood my ground many times, but that is, you know, I was the chief. That was my account. You know, I had tremendous confidence in the fact that I wasn't going to probably lose my job because of this new surgeon that came in and thought, you know, he had to do everything his way. And you can't, I don't think you can do that. You got to pick your time and pick your moment.
Yeah,
and make
pick
sure
your battles.
That,
You got to pick. You got to pick your battles.
That's not going to happen in a 2-week travel assignment.
No,
you know?
it's probably not. You're absolutely right. Okay, so let's do this if we could. How about if we take another short break, and I want to come back, and when we come back, I want to talk about where you see the current number of perfusionists, we'll call it the shortage. We'll just use the term. I don't like to use that term, but we'll use how about we use the reduced asset level. How about that? Reduced asset level. I like that one. And where if you're seeing it getting worse, stabilizing, or getting better. So that's what I'd like to talk to you about moving forward. So that, and then also want to talk to you about people who may watch this program that are thinking about doing what you do, and how would a person who's never done it before get started. So those are the two topics that I'd like to address with you guys when we come back from our short break, if that's okay with y'all. You don't mind sticking around?
Thanks.
Okay, and welcome back, everybody. We got Aaron and John back too. There they are. Hey guys. Okay, so I'd like to take, if we could, maybe the last 15 or 20 minutes to talk about, you know, where you guys are seeing the number of available perfusionists, you know, either getting worse in terms of, you know, having too few, or getting better, and where you think that pendulum may be as it inevitably will start to swing back. That's sort of the way the cycle works. You've seen this before, right? You've seen,
gosh, yeah.
You and I have both. Now, Aaron, you probably have. John, I know you've seen it. I've seen where there's been this kind of a shortage before. It was years ago, but then the pendulum swung the other direction, and there was a glut. There were perfusionists that couldn't get a job. There were people graduating from perfusion school could never get a job, and there was just so few. And of course, you know, it has an effect on salaries. It has an effect on all kinds of things. But now the pendulum seems to have swung back the other direction, and I believe that how far it goes either way is dependent on how far it goes out. So, for example, in our current situation, if the pendulum swung way up here and it was that much of a shortage, that when the pendulum comes all the way back, it's that momentum is going to carry it, and I can see where we may end up at a glut again. But there's other things too that you can, you know, there's challenges like how do we adapt? What kind of technologies should we bring into our business, into our practices and stuff like that? How do we, you know, you look at a heart surgeon. I know heart surgeons that amputate legs and feet because of whatever the reason may be. You know, they'll do chest work, they'll do, you know, vascular work, they'll do endovascular work, they'll do this, they'll do that. They're doing a lot of stuff. We are so pigeonholed. And I think that to survive this industry, we need to sort of get branching out a little bit and start looking at other things, other technologies that are extracorporeal in nature, requiring blood and pumps and pressures and all the stuff that we do, that we can add value to the facilities where we may work. That's what I think. But what that is, I don't know. Like angiovac, I think is great. I think angiovac is a great way to build a more robust caseload, so that when heart caseload is down, you still have that, because that's how you're going to survive. Diversity is what makes you survive. If you're just one thing, this is all I do, this is all I ever done, and that goes away or reduces, then you don't survive. So why don't we go with Aaron first? So tell us about where you think the current staffing situation is.
I wanted Mike to go first. That's a hard question. Can you guys hear me?
Yes.
Yes.
Yeah,
Okay.
we can hear you.
I have started to see that pendulum swing. So the laws of supply and demand. Right now we're in high demand because of low supply, and I'm feeling the supply is increasing.
Mm-hmm.
I'm feeling positions are starting to fill in, and I have just been feeling that probably the last 4 months, 5 months, maybe all the new grads from, the last graduation are kind of up and running, and they don't need cross coverage while they're getting trained, and they're taking their own call, and I'm feeling a little bit of that pendulum swing, honestly.
How is that going to affect, because you're young. I mean, you're comparatively very young. How are you planning your life to go transition from what you're doing to something else before there is not something else?
Well, I think I entered the field where new grads couldn't get jobs. There
You
were
did?
very little job openings, and you could just go. I was in '08, a graduate, and there were no jobs, and it was hard to get jobs. But even when you got a job, there still were travelers because you couldn't cross cover for vacations.
Yeah, there's always going
So-
to be a one-man account, even though I don't think there should be.
Yeah, or even if it's a 3-man account and they've got 3 surgeons because they're not in a +1 model, and someone wants to take a vacation, they still have to have 3 available, in case, an issue arises.
Yeah.
Yeah, so I just am. I've looked at settling down somewhere. I've got kids who are teenagers and a great home life where my husband works from home and my in-laws live next door to me. And so right now I'm not going to do anything to destabilize their roots and their future. So, hopefully I can just keep traveling. But I see a lot of people are branching out with BMACs and PRPs, PRP facials, outside of the open heart realm. Doing podiatry with BMACs, PRP facials, and picking up that business.
So, we're doing some plastic surgeon work too.
Yes.
And, regardless of what you think about it, I still think it's smart to have it as a service that you will provide. I question whether it has any real clinical value, but that's a different topic for a different day. If it's not going to hurt anybody, so I'm comfortable with that. It can't hurt anybody, and maybe it does do some good. I don't know.
Yeah.
John, what are you seeing in the market? What do you see the market trends at this point?
Yeah, it's kind of hard to tell because I'm focused totally on ECMO right now, which ECMO is growing, as we all know, and right now in the wintertime, the flu season just wreaks havoc. I probably get several calls a day, and I obviously can't take them. So that part probably is going to continue to grow, but it's hard to say. I've always thought in the years I've been doing it that it's very fragile, the difference between too many perfusionists and too few, right? It's pretty fragile. And you have a lot of schools right now that are graduating some pretty large classes. of students. And I know people are predicting 5 years, 10 years, the shortage is going to stay. I really don't know because it's of such a small field. It doesn't take a whole lot for it to swing back one way or the other. But having said that, I think, if we all want our salaries to continue to go up, we need something of a shortage, right? We need people who want us. So to embrace all these technologies, or at least a number of them, like HIPEC, AngioVac, and I've been places where it was PRP and BMAC, and even some other things. We can embrace these technologies and expand our field, and I guess we can always sort of let them go if we really have to. Like, we've been trying to let go of ECMO for 35 years. It still hasn't worked. It's working a little with ECMO specialists, but by and large, most places can't seem to get an ECMO specialist program totally off the ground either. So from my standpoint, I like the shortage. It keeps people calling me. It keeps driving up salaries. But if you're set at an account and you're constantly short, you can't go on vacation, go to meetings, the shortage gets old. So there's definitely two sides to it. But one other thing Aaron was saying, for example, if you go to a 3-person account, my very first job, for example, 3-person account, the 2 guys that were there before me had been there for decades, and they had 6 weeks vacation. I came in new, and my vacation was 3 weeks. But even that is 15 weeks out of the year. You're down to 2 people. And so that happens everywhere.
Everywhere.
Like Aaron knows at Orlando, I think we have 15 perfusionists. There's 2 on vacation every week. And that doesn't include somebody that might be sick or has to go out of town for some other reason. So you always have that element to it. So, there's nobody out there that says, I don't think there's a single account out there that says, well, when somebody goes on vacation, we're perfectly still fine with all the people we have. And I don't see that too often. So the vacation thing adds up, because you add up everybody in the group. Joe, you probably have this in your situation. You probably always have 2 or 3 people on vacation.
No, we have our rule is to have 2. I think it's two people can be off right now because we've grown enough. It was, of course, we were smaller, and so it really wasn't, a burdensome to say 1 perfusionist off at a time. But as we continue to grow and our volume grows, then now we can have 2 perfusionists off and 1 autotransfusionist, or 2 autotransfusionists and 1 perfusionist. So 3 people technically, I guess. Plus we have several. We have a couple, but at least 2 couples that work for us. So we don't have an anti, what is that called? It's not. Is it nepotism? Is that the term? Anti-nepotism rule, where you can't have a married couple working in the same place. But we don't have that issue. We do that. We embrace that, and don't have a problem with it. But it creates challenges because they want to go on vacation together, and so that. And if you have 2 married couples and both want to go on vacation together, it's not 2 people you're losing, it's 4. So can you just do me a favor?
One thing you guys hit on earlier, on the
please?
positive side of being a traveler, Mike touched on this. It is a great way to scope out the landscape and find a nice place to become a permanent place. Because you go for a week or 2 and you're like, hey, I'm not going back to that place. But you go to another place and be like, maybe I'll stay here longer. And before you know it, you're like, so it's a great way to put your toes in the water. And it's great because if you don't like it, you're not there for very long. And if you do like it, you know what you're getting into. You actually know what it's like to pump cases there. So the positive side to traveling is you really get to see and test out if you ever want to think about changing jobs. I don't know that the downsides are pretty large, but most people have to have a perfect situation to be a traveler. Like Erin just described, she's able to do it because her home life has everything put together in a certain way where she can go. Most people, they can't do that. Their spouse is dug in at their job. They can't just keep moving around. or they have kids that are too little or whatever. And in my case, my kids are grown, and I can pretty much go and come as I please. So I know a lot of people. I don't know about you, Aaron, but a lot of people come up to me and they really want to talk. Perfusionists want to talk about how do I do it, what's it like, and then usually they find out that their lifestyle isn't going to permit it right now. That it maybe
Yeah, that's correct.
some years down the road they could think about it, but they just can't be getting up and being in a different town 2-3 weeks out of the month. You know?
Yeah, that is correct.
And-
I have a lot of heart surgeons that are talking about their shortage and how
Oh,
their
yeah.
caseload is just increasing. All these baby boomers are getting older, and there's just so much more
I'm one
of
of
a
them.
demand for them. Their supply is down, and that their caseload is just getting heavier, and that there's more people having procedures, and they don't see any like future of a diminished need for perfusion or perfusionists.
Well, look, I mean, 40. Okay, I graduated from my perfusion training in 1979. That's when I graduated. Okay, so I was told not long after I graduated my first job, which was at St. Thomas Hospital in Nashville, Tennessee, and this person, I can't remember who it was anymore, but they said perfusion isn't going to be around in another 10 years. Forget about it. So I was like, okay. So, you know, I worried about it a little bit because I was new, I was young, you know, whatever. But I worried about it, but wasn't preoccupied. 10 years came and went, and I was busier than I ever was. I'm like, well, that guy was wrong. But somebody else told me in another 10 years, there won't be any perfusion. PTCAs, I think, had just kind of started. Grunzig, the original Grunzig procedure. Perfusion was just going to be gone. And I was thinking, you know, of course, I was a little smarter then. And I was like, well, what are you going to do for valves? What are you going to do for type 1 dissections? What are you going to do for, you know, for dilated aortic roots? What are you going to do? I mean, I was like, that doesn't even make sense. You know, what are you going to do for ASDs, VSDs, congenital defects? Perfusion, where's it going to go? So I, didn't really pay that much attention at all. Another 10 years goes by. I'm still busier than I ever was. And then somebody else tells me, I have been told 4 times in 41 years of actually working after training that perfusion was not going to be around in another 10 years.
Right.
And we're still here. I don't think there is a substitute. Now, John, you brought up a very good point. But before, about the ECMO, because I want to talk about that. But where do you see, what are you seeing?
I'm seeing that there is at this point, there's still a relative shortage. And there's a lot of reasons for that. And one of the ones we haven't touched upon, but I'll just real briefly, is a lot of people are looking for that perfect position to be in. And they are transient in their length of stay at a job. They'll get something looking for their chance to find that other place down the road that they would rather be. There's always going to be those what are considered, in a former company that I worked for, hard to fill positions that I think will always run the gamut of not having enough people. The places that are lovely, and I guess, the Colorados of the world, the Californias of the world, they may not have that much of a problem. But other places, not too many people want to go to Anchorage, Alaska.
Or Drury, Erie.
Or Drury, Erie, or places like that. So I think a lot of it has to depend on where the account is as to whether or not it historically has people, shortage of people. Getting back to what you were actually asking me, though, is and once again, the question exactly was, I want to answer.
Where do you see the staffing going? Where do you see the shortage? Is it getting worse, staying the same, getting better?
I think it's still
or reducing
short right now. I think, as Aaron might have alluded to, that we're starting to see a slight shift with the graduation of the classes. We're still looking for somebody, I believe, here locally in Houston.
We are.
And you also have to put another variable on that. A lot of times you can get a perfusionist, but are they a good perfusionist? You know, the good ones are really hard to find, and the good long-term dedicated ones are almost non-existent. So I think there'll always be positions for guys of my age. Although you told me I can't retire, I'm going to have to retire one day. I'm just going to be too old to do this stuff. And so there's got to be somebody come along to take my spot.
You can retire after I retire.
Okay, we'll talk.
I
about
get to go
that.
first.
Okay, you can go first.
I'm senior. So, and John, you talked about the ECMO, but first, let me ask you, Aaron. I want to add to that too. You're married. You have teenage kids. Your husband works from home, and you're traveling away on the road. What kind
Correct.
of a strain does that put on your relationship, if any?
Well, you have to flip that same coin, Joe, because the benefits can also be great, depending. So being away can be hard and there can be a strain, but if you know you have to be home for something, then you know that you can make your own schedule, and that you can be there for all the important things. So it's a double-edged sword, or just two sides of the same coin. Of course, there's strain. I think it's easier now than perhaps a decade or two ago, with the video chatting, and I get to see, my children every day and talk to them, and help with their math homework, all through video chatting. And then when I need to be at something and it means a lot to them, then I make sure I'm there. Same for my husband. If something comes up with him, with my family, then you have that flexibility where you can take the time off. So there are strains, but nothing in life is easy, and there's a lot of benefits as well. I was always stuck at places where we had no coverage. We couldn't plan a vacation. I've had countless vacations canceled because we couldn't get anyone in to relieve me. I missed everything for my kids. I couldn't schedule a day off. And that's my kids' memories from their childhood up to this point. So it's difficult when I'm on the road for long periods of times, but then when I'm home, I'm 100% at home with my family, with my kids, and with my husband. So it has its benefits.
Well, I think that ultimately, because I am very sensitive to what you said. I missed so many Christmases I can't count. I missed
Me too.
all of the little concerts that they would do at school. I missed everything, and I regret it. I regret it. However, and I think you'll have the same experience, the kids, as they grew up and kind of understood life from a different perspective, respected it. They regretted it too, but they understood why. They didn't have that sense of, you weren't here for me, because you were there. You were just doing what you had to do to make sure that they had what they needed and wanted. That's the luxury of life. Everything comes at a cost, right? But but ultimately, I frankly regret it. I think that I had this thing in my head. I wanted to be the best of the best perfusionist in the world, and to do that, I had to always do another case to prove that to myself, or whatever it may be, and that was stupid.
Yeah, it's like you come out of school thinking that way, but then all of a sudden you meet a very special person in your life, and you said, now my efforts are changed. I want to be the best husband I can ever be. And then when you have that child, you say, I want to be the best father I can ever be. And you start thinking differently about your commitment to the perfusion. It's still there, and you give it your all. But getting away from it is so important to have a normal life. Most of the things with my daughter I was able to see. I only had one child, so that helps. You didn't have to split between two things like you have to do, Aaron. But my wife missed out on a heck of a lot. and I owe her a lot. I'm going to have a lot to make up to her in the last, 25 years of my life.
Yeah.
And so that's what I'm planning on doing. And so that's why I got to retire, Joe.
That's right. Retire with the lifestyle that we all want,
Yeah,
right?
we all want,
exactly.
yeah, that's for
so
sure.
I get that. But so John, ECMO, and Aaron, you can go in on this too because you do. I'm sure you do ECMO shift relief, and that's.
Yes.
I'm assuming that is a not insubstantial part of your practice. Is that? Do you think that's accurate? I wasn't sure.
Yes.
And I think
Yes.
ECMO is not going anywhere. So, John,
I
given
know of
that
two small towns just in the last week that I got a call from. They're trying to put together a pool of ECMO perfusionists that they can call if and when they launch their program. Small towns.
but they have perfusionists in town.
I guess.
I mean, I would hope
yeah,
so.
I guess so. Must be a heart program that's expanding into ECMO, and their
Right.
perfusionists have said, you better find people to cover it when you do because we can't. I guess that's what's going on because it's two programs that I got notified of in small towns that they want to launch an ECMO program, start doing ECMOs, and they're already calling out months ahead of time. Let's get a list of people that we can call that can cover this if we do this. So apparently they don't have their perfusion staff and planning on not doing a whole lot of it. But the reimbursements are tremendous. The cases are everywhere. The flu, you name it, are everywhere.
Yeah,
And
there's all
now
kinds
the
of
success
infectious
is
diseases.
substantial.
Vaping. Now there's Valley, vaping associated lung injury, which is a diagnosis. I didn't even know that.
Yep.
A new diagnosis. And these kids are using this. I mean, that's, I think acute pulmonary dysfunction failure is not going anywhere. And I think that, we're going to have to learn which diseases are reversible.
Right.
What's not reversible? When should we use the ECMO? When should we not use the ECMO? And all of that will have to vet itself out over time. But in the short term, ECMO usage is still growing. It is outpacing our ability to train people.
Yes.
And so this is going to be, it is antithetical to what I used to believe, and probably I don't know. And some people get very upset when I say this, but wouldn't it make more sense? And I want both of y'all's opinions and yours too, and don't hold back, okay? Just give it to me how you feel. But wouldn't it make more sense for that program that is expanding into ECMO, where the perfusionists say, you better find some people that are going to be able to come in here and watch this because we don't have enough people to do that. And ECMO is so, if inconsistent, it's hot and cold. So it's hard to say we're going to hire 2 more perfusionists for this department because we're going to have all these ECMOs, and then you don't have ECMOs for 3 months or 4 months, and then you end up having to let somebody go, and that's very disruptive. You can't do that. So wouldn't it just make more sense to have a blended program? You're in a smaller town, you got a perfusion program, they're very qualified to be able to do the insertion, get the patient stable, and then train the nurses to monitor the ECMO, but put them through an actual nurse ECMO specialist training course, not just teaching them, you just do this and this. I mean, that I'm talking about doing it more formally, and then have a blended program where you oversee it, you do the insertions, you do the change outs, you do rounds on it, maybe once a day or once a shift or whatever it may be, twice a day, whatever. You have phones, FaceTime, it works. You just said it yourself, you connect with your family. That's what I think, because I don't really believe that we can fill all of the positions that will be needed to cover all of the ECMO for a 3-month window. Because what do you do with the rest of the time? And so, from a market perspective, that's very difficult. Staffing is very, very complex when it comes to ECMO.
Yeah.
It's one of our biggest problems. So, John, you first.
Yeah, you hit on a big thing. I mean, you have a lot of accounts that they do an ECMO every now and then. I just came from not a small town, but a medium-sized town. They called me for ECMO, and I asked, well, how many have you guys done? Well, we don't really have them, all that often. I go, 8 a year, yeah, something like that. So you're talking about a lot of downtime for whoever's covering that. And is that person going to sit around, or are you just going to keep calling outside people and piecing it together with the perfusionist with some outside help, which is what a lot of places scramble and try to do. It's a complicated one when it comes to staffing because it can be so inconsistent.
Yeah, and if you want a good program, you need the same people, to have that continuity. You got a new perfusionist coming in every time you have an ECMO, there's no continuity from one patient to the next. You're not building upon your program.
Yeah, I mean, your CCM physicians aren't seeing it all that often. The nurses see the ECMO, not all that often. Maybe it's different nurses the last time because the assignment or they've left. And, I don't know what the answer is. The ECMOs that I'm seeing they're getting a little more complicated. They're getting like problems that we see sometimes, getting more complicated with what's really going on with the patient. The combination of the ventilator settings with the ECMO, the different cannulations for VV, you can have so many different arrangements.
Very exotic cannulations we have now.
The one I just left had femoral vein right IJ, which are shooting right at each other, right? How much mixing was going on?
Do you have an altimeter yet?
Yeah.
Did you get one of the meters?
Didn't have an SpO2 monitor.
No,
I didn't have an SpO2 monitor, so I couldn't even tell what the SpO2 was.
No, but did you get the
incoming line?
Did you get the altimeter yet?
They declined it.
They declined it?
Yeah. It's
oh my
crazy.
goodness. We did it the other day. We've had another patient, and we did. Are you familiar with the altimeter, Erin?
No.
Oh, I'll tell you about it. Okay, so what's your view on it? How do you feel about what I said and then what John echoed?
With the staffing issues
Yes,
associated
in terms
with
of
ECMO, I
training
think
nurses to be ECMO specialists.
I think in community-based hospitals where they're putting them on and getting them out, I think it should be perfusionists because those are a lot of the crash and burn cases, and it is they don't have a pulmonologist. If it's VV, they don't have an intensivist. The surgeons aren't available. They're trying to sleep because they have a big case in the morning. I think in those scenarios, I feel like it's best that perfusionists, keep hold of the reins. As you get into larger institutions where ECMO is more mainstream and everyone is comfortable with those very sick patients and getting sicker patients, and it makes sense for the program to train specialists. I mean, as long as it's okay with the state and the licensing and whatever else. I'm not familiar with how it is across state lines in capabilities, but I think that, training nurses, respiratory therapists to help is fine, if it's more mainstream at that particular hospital. It's a little bit less of the critical thinking, a little bit less of the troubleshooting. Patients are a little bit more stable. There's a lot of other advanced practitioners that are familiar with the patient care. And I think that provides a little bit stronger of a safety net in case something should fall through.
Yeah, I think so. I think that my opinion is that if the patient is stable, once you have the VV, it works, everything looks good, oxygenation goes up. You get the vent down to rest settings. And the patient's. It's just we spend a lot of hours at the bedside
Yeah.
doing nothing. Okay, really, I mean, doing nothing. If you're having to make all of those adjustments on a continuous basis, well, that's a pretty unstable patient. It's pretty unusual too. Usually those cases don't last that long, so you don't need to do anything when you're having to make that many decisions on an ECMO, because usually it goes in, they get stable, and you're on cruise control until something either happens or you're going to make a change. So the ELSA meter, let me tell you about this. It's a little monitor, very easy to use, has 2 flow probes that are connected, as into one, and it plugs in. You put one flow probe on the outlet of your oxygenator, just far enough away so that you're out of the turbulent flow zone, and then you put the other one on the access line as close to the patient as you can. Now, this is for either VA or VV. It doesn't make any difference. But for VV, that's how the setup would be. And what you're looking, actually for both, the setup is the same. But it does 2 measurements in VV. It measures the intra-oxygenator blood volume. So if your oxygenator's blood volume, the priming volume on is 220 cc's, let's just say, and you have 160 cc's in it, you have 60 cc's of space has been occupied by something. It's probably not styrofoam or hamburger buns. It's more than likely going to be clot. That's about the only thing that it could be. So gives you a notification that your oxygenator's volume is decreasing because you're developing clot and taking up that space. So that's the first thing that it does. And it does that for VV or VA. With VV, it also measures the amount of recirculation in your either single or double cannulation technique. Doesn't make any difference, but it tells you how much recirculation there is, and then it gives you an effective therapeutic flow. So if you're flowing 4.8 liters and you have 15% recirculation, your effective flow is going to be somewhere around 4,000. So that's really good. But if you have 46% recirculation and you're flowing 4.8, and you're wondering why you can't turn the vent down, it may very well be that cannula position is not optimal and an adjustment could be made. You should do it at baseline as soon as you go on ECMO. You should, if it's VV, you check it for, if it's VA, you don't do anything obviously, but VV, do a measurement, get your baseline oxygenator blood volume, make sure that correlates to what the MFU says, and then you get that recirculation percentage, and then when you go to the ICU, you check it again, and well, you can, of course, if the position needs to be changed, you're right there to do it before it gets secured. But then you also check it when you get to the ICU to see if during transport something got moved. You just never know. Right. So it's a really neat tool. It's made by Transonic, so I'm going to give them a free advertisement. Transonic ELSA meter, ELSA. Really good tool to have, I think. Okay, so I think we're about, we went a little further than I thought we were going to go. I can't thank you guys enough for having done this, Mike. I always love to see you. And I've really enjoyed having you here, Erin. It's been a real privilege. And John, of course, it's just always good